Okay, thank you.
Okay, great. So good morning, everyone. Let me just share my screen with you guys. Okay, perfect. So, as mentioned, my name is Sasha Bernard. I am a public health educator by profession, and it is my honor, right, and a privilege to be able to present to you today on the topic of heard, trusted, acted upon, the role of culture in health communications. And I want to give a special thanks to Alison and the Delta Omega team for creating this platform and for the opportunity. So, I figured that I'd start off with a few facts about me so that there's a semblance of familiarity and it won't be that a complete stranger is talking to you for the next few minutes. So I am Sasha, as you know. I am a two-time alumna of Loma University. I graduated in 2017 with my master's in public health in global health, which is when I was inducted into Delta Omega. And then again in 2024, when I graduated with my Doctor of Public Health in Health Education. Uh, as just a quick plug to Loma University, I had an amazing experience there, and my passion for public health definitely grew in that environment. I consider myself to be an ambivert, but I do love people and health, so sometimes I am mistaken for an extrovert. Career-wise, I have experience in corporate, public government, and nonprofit sectors in the US and the Caribbean, which are absolute melting pots of cultures. And I currently work at the New York City Department of Health, where I am the health education specialist for the oral health program, which is housed in the Office of School Health. And last but not least, I am US born but Trinidad raised. So that is the accent that you are hearing for those who may or may not have been wondering. So our objectives today are very simple, very straightforward. We are going to define health communication, define culture in public health, understand a bit about health communication versus health literacy. We're going to acknowledge the influence of culture in health communications. And then last but definitely not least, explore some practical ways to present culturally competent information. So we have a problem. The problem is that health information and messages are often overly complex, making them hard to understand and hard to use. So, I have some examples here. Individuals experiencing persistent cephalalgia should consider pharmacological intervention. Epidemiological evidence indicates a 30 to 50% increased probability of morbidity associated with tobacco use. Utilize barrier methods during sexual intercourse to prevent transmission of sexually transmitted infections. So, what we see here, or what we should see here, is that when health messages rely on jargon, long sentences, or technical statistics, they can confuse audiences. But every problem needs a solution. So, what's the solution? The solution is health communication. Health communication can be used as a public health intervention, and it works by using plain language instead of medical jargon, focusing on clear actions that people can take to improve their health, using visuals and real life examples to simplify information, and tailoring messages so that the audience's culture, language, and health literacy are all taken into account, and that the information, and so that the information is relevant and easy to understand. So we see here, we had the three complex statements. So individuals experiencing persistent cephalalgia should consider pharmacological intervention. More clearly stated, if you have a headache that doesn't go away, talk to your doctor about treatment. The epidemiological evidence indicates a 30 to 50% increased probability of morbidity associated with tobacco use. Simply put, smoking greatly increases your risk of disease. And then utilize barrier methods during sexual intercourse to prevent transmission of sexually transmitted infections. Simply put, using condoms helps prevent STIs. So let's get into health communication a bit more. What is health communication? Well, Gary Krebs is a prominent health communication scholar and educator, and he's done quite a bit of work on the subject, and he defines health communication as the central process in the provision of healthcare delivery and the promotion of public health. Another scholarly book defines it as a field that's focused on employing communication strategies to shape and improve public health, emphasizing disease prevention and health promotion to enhance well-being and quality of life. But simply put, health communication is the process of sharing health information in ways that help people to not just understand it, but to use it to make informed decisions about their health. Now, we know that communication is at the heart of who we are as human beings. So let's dive a bit more into why health communication is important with two main facts. First, effective health communication is critical to health and well-being and can impact health outcomes. Second, poor communication widens health disparities, reduces trust, and reinforces misinformation. So basically, it's important because it empowers communities, reduces health disparities, increases trust, and promotes public well-being. And that's what we really desire in public health, right? So we've seen that health communication, by definition, is the use of communication strategies to inform, influence, and motivate individuals and communities to improve health. But what is health literacy? Well, health literacy is the ability of individuals to find, understand, evaluate, and use health information to make appropriate health decisions. So how does health communication and health literacy work together? Well, effective health communication improves health literacy. Higher health literacy enables people to interpret health information correctly. So we see that there's a sort of bi-directional relationship there. But together, they lead to better health decisions and healthier behaviors. So this is just a quick visual to help put things into perspective. So here we see how the combo of health communication and health literacy is what transposes or transforms health information into actionable, measurable effects. And we always want to ensure that we account for the health literacy of our target audience when preparing health communications to ensure that the information is being shared is used to help people make informed decisions and to improve public health. So how do we account for that? Well, some of the things I mentioned previously, using plain language, clear actions, visuals, culturally appropriate messaging, so that people can easily understand and apply the information to their health. So let's get into the meat of the matter, culture. So according to the CDC, Centers for Disease Control and Prevention, culture can be defined by group membership, meaning groups of people of a similar race, ethnicity, language, religion, location, or it could be defined as a collection of beliefs, values, customs, ways of thinking, communicating, and behaving that is specific to a group. The ideas that people have about health, their health literacy, and the context in which they communicate about health often reflect their cultures. Cultural beliefs or memberships shape how individuals perceive their health, how they perceive illnesses, how they perceive the risks to those illnesses, how they perceive treatment, and it also influences their interactions with healthcare systems and providers. So let's look at some examples here. As it relates to traditional healing practices, some cultures may prefer herbal remedies or traditional healers before seeking medical care. This can influence when and how they access healthcare systems. If we look at beliefs about causes of disease or illness, in some communities, illness may be believed to be caused by spiritual factors, fate, or imbalance, rather than biological causes, which can affect the acceptance of medical treatment. As it relates to preventative care perception, certain cultural groups may only seek healthcare when they are sick, rather than for preventive services like screenings or checkups. Dietary and religious practices, cultural or religious beliefs may influence food choices, fasting, or restrictions that affect nutrition and treatment plans. In some instances, cultural food traditions may also influence diet-related conditions like diabetes or hypertension. And then it relates to trust in healthcare systems, in some cultures, people may actually rely on families or elders to make health decisions rather than deciding alone. And then, based on historical experiences or community narratives, it can influence trust or mistrust of healthcare providers, which may impact willingness to seek care or follow medical advice. But as public health professionals, health decisions are not made in a vacuum. That's something that we should always keep to the forefront of our mind. The health decisions of communities, of individuals, are always shaped by their culture, their traditions, their family practices, and their trust in health systems. So understanding these beliefs and memberships is essential for promoting effective health communication, improving health outcomes, and ensuring culturally competent services are provided. Now, it's no secret that the communication process is complex and it's fragile. It can confuse, it can frustrate, especially when it is not culturally sensitive, appropriate, engaging, and informative. We often underestimate the difficulties inherent in sharing relevant health information with people who come from diverse cultural backgrounds and have limited levels of health literacy. So recognizing culture as a factor associated with health and health behavior, as well as a potential means of enhancing the effectiveness of health communication programs and interventions, is of ultimate importance. In the context of health communications, culture should be viewed and applied as a complex and a dynamic variable instead of a variable that is simple and fixed. And we need to always account for the fact that culture does affect the acceptance of health communications, including preventive or health promotion methods. So to be fair, we can say with surety that culture and health literacy influence how people understand, interpret, and act on health information. Now, I can't see the chat right now or the questions answer, but if you do have the ability, please show me a thumbs up. Let me know that you're with me, that you're following me, that I'm making, some sense to you guys, because we are going to get into the exciting part of this presentation. Now, sometimes the merge of culture is straightforward, right? Like linguistics. You go into a predominantly Spanish-speaking community with English messages that are not translated or do not translate well, it's a problem. Or let's say you go into a rural community where education is not necessarily a priority, but your messaging is filled with statistics and hard facts and medical jargon that is anything but plain. But what about when it takes a little bit more consideration, a little bit more learning? So let's look at a case scenario. I have two case scenarios for you guys. The first one focuses on a Caribbean community, because remember I told you guys I'm from the Caribbean. So a hypertension campaign launches in a predominantly Caribbean neighborhood. The messaging of this campaign says, cut the salt, avoid rice, stop frying your food. Very corrective, very clinical. And it uses images of unfamiliar foods and Western style meals. Now, what was not considered in this campaign is that food is deeply tied to identity, memories, family traditions. Sunday meals in this community are cultural rituals, and elders are respected voices in dietary practices. So when this campaign was launched, the community felt as though their culture was criticized. So they did what anyone who felt dismissed or looked down upon would. They dismissed the campaign. And that resulted in minimal behavior change, meaning that the campaign was not successful. However, the receptiveness of the community improved when the communication shifted. So instead of saying, cut the salt, avoid rice, stop frying your food, it said, keep the flavors, but protect your heart. And instead of using images that were unfamiliar or food that was unnecessarily cultural, it used demonstrations of healthier versions of traditional dishes. So those who may be familiar with, Caribbean dishes that are traditional, your roti, your doubles, your ackee and saltfish, right? And then they also engaged local cooks and community leaders instead of just laying it on the community from these strangers who they'd never heard of before. So the lesson that we can learn from this case scenario is that when culture is treated as the problem, the message loses power. So we always need to not dismiss culture and think that we can run a campaign or promote health education or give any kind of communication without considering culture because it leaves our message powerless. Let's look at a second case scenario. We're going to look at a faith-based community. Now, a vaccination campaign. Those are very sticky sometimes, right? But it rolls out in this tight-knit religious community. The messaging for this campaign emphasizes follow the science, don't let myths mislead you. And the campaign relies solely on government channels. So what wasn't considered for this campaign is that health decisions are often discussed with faith leaders, and the body is viewed as sacred and guided by spiritual principles, and that the congregants typically look to pastors for moral framing. So when this campaign launched, the community felt hesitant. Rumors turned into misinformation, which became more impactful than the campaign itself. Receptiveness improved when communication shifted to a partnership with pastors and ministry leaders, and they framed vaccination as stewardship and protecting the vulnerable. And I would assume in this campaign, they probably had like a health fair that was hosted by churches and, utilizing the community and the culture of that community instead of shunning it. The lesson for this one is that ignoring religion doesn't remove its influence. It only removes your access to trust. We can ignore it as much as we want as public health professionals, as health communicators, but it doesn't remove the fact that it has a huge influence on the community. So it only removes our access to trust, but it doesn't change anything else. So what we need to do is embrace it. Embrace the culture, embrace the memberships that these people belong to, embrace their beliefs, their values. We don't have to agree with it, but we have to embrace it. Now, healthcare providers, and I'm not talking about just doctors and nurses, I'm talking about any professional, any organization that delivers medical, dental, and preventative services that help individuals maintain and improve their health. So I'm talking about all of us. We are likely to provide better care if we understand what distinguishes our patients' cultural values, beliefs, and practices from our own. So the emphasis here is on culturally informed communication. We want to be culturally competent. Now, this culturally informed communication refers to the tailoring of health messages and interactions to respect and align with diverse communities' cultural norms, values, beliefs, and practices. We always want to seek to understand our audience. And when I say audience, I'm talking about the overarching group and the subgroups. So listen to understand. We're not listening to debate. We're not listening to respond. We're listening to understand and asking questions if needed. No one expects us to know it all. No one expects us to understand it all at first. Asking questions allows the community to see that, hey, they're interested in what we present, what we offer, who we are. So it builds trust. Seek out a gatekeeper if needed. We see from the case scenarios, the gatekeeper could have been the pastor or the spiritual leader, right? The gatekeeper in a Caribbean community might be someone who is older, an elder person, but the gatekeeper is technically someone who is immersed in that culture, in that group, in that membership, someone who knows the membership because they are a part of the membership, and they can then guide you in the best way to enter into this culture, right? We want to understand the needs before determining solutions. needs assessments, very important. We can't just decide, hey, we are going to do health communications in this community because we want to talk about oral cancer. Absolutely not. No. We need to determine if there's a need. What's the need? Maybe we see a prevalence of lung cancer. So we determine then, okay, maybe they are high tobacco smokers. There's a high rate of tobacco smokers in that community, which leads us to then wanting to speak about oral cancer. But we need to determine what the needs of the population are before determining a solution. And then practicing cultural humility. We want to be open. We want to show respect and we want to be adaptable because we don't know it all. And we're not familiar with every culture that exists in this world. So we need to practice cultural humility to be culturally competent. So my final tips and takeaways as I wrap this up, culture, and health communications go hand in hand. We cannot take it for granted that culture does shape health behavior. Trust and health literacy are foundational. What you say, how you say it, when you say it, where you say it, they all matter. Collaboration is key when working with cultures. You're not expected to know or to understand it all. The success comes in togetherness. And pilot communications, it won't always work the first time. Most times, it's also not a one size fits all. A Jewish population in the Bronx can be very different from a Jewish population in Manhattan. Culture is not a one size fits all as well. So, piloting communications ensures that your communication is tailored for your specific community, your specific audience at that specific time. What works today might not work tomorrow. It might not work for someone who is, as I mentioned, someone who is African American in the Caribbean. It might not work for someone who's African American in the US. And then last but not least, effective health communication is culturally sound and builds understanding, trust, and partnership. And I'm going to repeat that one more time because it's really important. Effective health communication is culturally sound, builds understanding, trust, and partnership. So I thank you so much. I hope that you did take away at least one thing from this presentation. I'm very much open to networking. If you want to connect with me, please feel free to connect with me on LinkedIn. That is my name on LinkedIn. You can shoot me an email. You can message me on this chat. I would be more than happy to answer any questions that you may have. And again, I want to thank you so much for your attention. Again, I hope you learned something. And I now hand it over to my colleagues at Thomas Jefferson for their presentation. Thank you.
All right. Thank you, Dr. Bernard. That was excellent. Fantastic. And thank you for Delta Omega for inviting us today and sharing the spotlight here with Dr. Bernard. I am inviting Yawei, Dr. Sifat, and Theba to share your cameras and join us, and we'll do some introductions, and I have some slides. And so, hi everyone, I'm Amy Leader. I'm a professor of population science here at Thomas Jefferson, based in the Cancer Center, and our associate director for community outreach and engagement. And I teach in our public health program at Jefferson. I'm joined by Theba Ahmed, who is a current MPH student in our program at Jefferson. She will be followed by Yawei Song, who is an MPH alumna of our program and the current program manager for community outreach and engagement, also at the Cancer Center. And then we will round it out with Dr. Munjireen Sifat, who is an assistant professor of population science here at Thomas Jefferson. Does not have her MPH from here, but from George Washington University, but is part of our Delta Omega chapter now, which is awesome. And she also teaches classes in our public health program, which is wonderful. So I'm going to share slides and be sort of the keeper of our slide deck here, which I should be able to do now. And we have multiple speakers. And so I'm going to kick it off and then I'm going to pass it to Theba. So our topic today, let me make these a little smaller. Our topic today is communicating with diverse communities to advance public health. So we're going to share some examples with you today. And we are affiliated with the Delta Psi chapter of Delta Omega at the College of Population Health at Jefferson. We are here in Philadelphia. Our chapter, our Delta Psi chapter, was established in 2019 at Jefferson, and our goal is to increase our alumni and our student engagement and interaction with the Delta Psi chapter, and bringing all these valuable networking opportunities and career opportunities to alumni and students. Things that we've done in 2026, as well as in previous years, as well as we have our LinkedIn networking group. We've done a few of these Delta Omega webinars now. We did one last year, and we're doing this one, and I believe we've done one more. We do an annual alumni stories panel for our current students who can hear from our alumni and the different careers that they're all working in. And in the spring, we're gearing up for our new inductees networking event. So just a few things we do here. And now I'm going to pass this to Theba. And Theba, I think it'd probably be best if you just sort of said next slide as you're ready to go. And I'll just advance it for you.
Sounds good. Thank you, Amy. So my name's Seva Ahmed. Hello, everyone. And today I'll be discussing the background information regarding health communication. And to communicate effectively with diverse communities, we first need to understand what health communication actually is, what frameworks guide it, and how concepts like health literacy shape what works and what doesn't work within health communication. Like Dr. Bernard previously mentioned what health communication is, and going off of that, at its core, it's the study and practice of using communication strategies to inform and influence individual and community decisions that affect health. And looking at this image, we have some examples of health communication tools, and each tool represents a different way we can engage with communities. So with surveys and needs assessments, those give us the ability to ask patients directly for feedback and use that to inform quality improvement within an intervention. Then focus groups and interviews relate to collecting qualitative, in-depth feedback from target audiences to refine any interventions. Experience-based design is about co-creating health services with patients using their real lived experiences to guide what we build. Assessment and evaluation uses tools like the patient education assessment tool and the health education materials assessment tool to rigorously evaluate whether the materials are actually landing within the audiences. And finally, patient advisory boards are groups of community members who provide ongoing feedback on materials and services. Next slide. Cultural adaptation frameworks come into play to ensure our communication is actually reaching the people in the right way. And this image over here follows Barrera and Castro's cultural adaptation framework, and it maps out into 5 sequential steps. It starts with information gathering, which involves reviewing the literature on group-specific risk factors, as well as conducting qualitative research with the target community and key informants. From there, we have preliminary adaptation design, and that's where you develop a culturally adapted version of the intervention by integrating stakeholder input, maintaining health literacy, and incorporating community feedback. From there, the preliminary adaptation tests is where you pilot the intervention with real staff and participants, as well as collecting both qualitative and quantitative feedback. Adaptation refinement uses what you have learned from the initial feedback to improve the intervention. And finally, the cultural adaptation trial consists of rigorous evaluation of engagement outcomes and what needs to be refined further within the intervention. Next slide. Moving on to health literacy ensures messages are understandable, actionable, and accessible for all communities. Key considerations to keep in mind is that first, interventions must be designed with different literacy levels in mind from the start. Second, low resource populations often face the greatest health burdens and have the hardest time accessing information that wasn't designed with them in mind initially. And third, it is absolutely critical that we use culturally appropriate language and that staff communicate clearly and equitably for everyone. Next slide. So with that theoretical framework in place, here are the 4 best practices when it comes to health communication, specifically with diverse communities. First, it's to understand your audience, which means doing your research, looking into languages, cultural backgrounds, age, and community needs. And more importantly, you should invite community members to help create these messages and materials. Second, it's tailoring your messages for health literacy. And this means to adapt content so it's clear, easy to understand, and as well culturally sensitive. This also means matching the format to the audience, which includes their literacy level, their cultural values, and their attitudes toward health information. Then we have choosing appropriate communication methods, which reminds us that there's no physical channel for communication. Communication could be anything, which includes live presentations. It could be something physical, like a pamphlet where someone can take home and share with the rest of their family. And it can even be digital through social media. And lastly, there is feedback, which includes monitoring how messages are being received and to use that feedback continuously to improve your intervention. And the key takeaway here is that health communication is bidirectional and it's a continuous loop of listening, designing, testing, and refining your materials. Thank you.
Thank you, Siba, for the background information. So I will share some examples of how to tailor health communications to meet the cultural and linguistic needs in the local Chinese community. Next slide, please. So the first example I would like to share is the co-development of this one-page cancer infographic in partnership with our former community advisory board member, the Chinatown Clinic. So our goal is to raise awareness about cancer in the Chinese community. So after talking with our advisory board member, we learned to do that, we need to first address cancer as a taboo topic within the Chinese community. So the title of this infographic is why it is important to talk about cancer. Why it's important to talk like what is cancer, why it's important to talk with your families and friends, why it's important to talk about that with the medical providers, and also what is the confidentiality that is built in place within the healthcare system in the US. And besides that, our community partner also suggested the images that we put in here. So you see it's a multi-generation image because we really want to leverage on the family connection, the tightness as a family value within the Chinese community. So maybe if grandpa doesn't want to get cancer screening, but maybe considering this could be something benefit for the future generations, maybe that could be one way we can approach and deliver the message. Next slide, please. And the other example I would like to share is how the health communication is being used throughout this program design, implementation, and evaluation process. So what we did is this is a pilot project, the Chinese Wellness Culinary Circle. So we're again leveraging our community partner in a local church. So here is an example of the recruitment flyer. So you don't see any QR code because we are really listening to our community partner doing a very traditional way, distribute this through church sessions. And on the right-hand side is the back of the flyer, which on the bottom, there's a name, like age, phone number. So it's like a simple registration form. So when our community partner distribute this flyer with their community members, the bottom of this like registration form can be tiered apart and we can collect that information. And then the participant can keep the upper half of this flyer as a reminder of this program. So we're learning from our community partners in what is the best way to approach our community members, but also in this case, like how we can do a better job with like research or project recruitment. Next slide, please. So here is an example of the first draft of our education slide. I would like to pose this question to all of you, if you can use the chat function. Like, what would you do to change or some recommendations to make this slide a little bit better? So this is a slide we are trying to provide the information on what is the bidirectional communication between the brain and the gut. So you can considering yes, so it's all caps, which make it very hard to read. And it's also, they have so much content on this slide, right? It's like too busy. And also at the beginning, when we have this red color as the background, is really from our research team reading the red color is really a lucky color, important color for the Chinese community. But in reality, this red background with white found is really hard to read, right? And also on here, the left, we have this image, but the image doesn't really convey or help the audience to understand what is this brain and gut connection, right? So it is important when we're trying to pick images, like, does it really gonna help us to convey, like to communicate with our audience, or it doesn't really provide any benefit? Next slide, please. So last part of this project is the evaluation. Given this is a culinary circle, we have some nutrition, so diet. We're hoping we can see some diet behavior changes. So in the evaluation question, we also adapted the question to include more examples for cooking ingredients that is more relevant for our targeted audience. So we added bok choy, turnips, like soybean, mung beans. So those ingredients are more relevant for our Chinese communities, like every day, like what they use. So when they answer those questions, it can better reflect on whether there's a true like behavior changes. Next slide, please. So to sum up, also like what Dr. Bernard explained earlier, like cultural is really important in shaping health beliefs. And what we learned from the textbook may already be outdated. Like it's good that we're aware that culture can be a very dynamic process and there might be a lot of changes or nuance between different subgroups. So we always want to try our best to collaborate with a community partner who are truly the member of our targeted audience, so we can make sure the content we develop is really relevant for them. And also to consider when we're working with the community group that English may not be their first language. It's great that we can using professional interpretation or translation services, but also whatever materials we developed, it might be helpful to pilot with community members or either having community members proofread it or back translate it to make sure the content are accurate. And lastly, just some tips on the good design that can help your readers, like the layout, the font size, what the color we pick, right? There are some tips on like what to do and what not to do. That will be all for my presentation, and Dr. Sifat will be the next.
Thank you, Yawei. So I will be talking a little bit about a research study that I'm conducting. It's called Project eShift, and the focus of this study is on people who have experience of homelessness and smoking cessation, smoking reduction. Next slide, please. So first, to set the stage of, and just give a brief background on why I'm even doing this study, and kind of going off of what everyone has already said on this panel, where you really need to know your community and the population you're working with in order to communicate with them. So first, you should know that the smoking rate among people who have experienced homelessness is about 70%, whereas in the general population, it's about 12%. So we see very high rates of smoking in this population. And despite the same number of quit attempts as the general population, they're much less likely to succeed in quitting. And so some of the things that we have to think about are the unique barriers that this population faces. And we can't make an intervention in, say, a hospital setting and hope that this population will come. You have to meet them where they are. So to do that, we first, given the lower access to care, we contacted them where they are. So we partnered with Housing First organizations. And that's where we mainly communicate with them. The population also has a distrust of clinical language and sometimes even clinicians. And so it was very important that we use lay language for this population. And of course, the larger issue at hand was that traditional smoking cessation methods don't work in this population. And so we had to shift and pivot to something that was slightly more innovative, which is how the study came about, where we're using FDA-authorized e-cigarettes as a form of harm reduction for this population. Next slide, please. So, of course, we always want our research and our work to be equitable and so people are having informed consent while they're working with us. I think that's especially important in unhoused populations because the experiences that they've had themselves by being unhoused can be a trauma for them. And so you have to make sure that they are really understanding what research you're doing and what they're consenting to. So one of the things that we did is it's not enough to just hand them a form, have them read it and sign it. We actually sat down with them and read it through with them to ensure that they could understand everything that was happening. You also want to make sure you're using non-judgmental framing and trauma-informed tone. So one example, we don't ever say smokers anymore. We use first-person language and we say instead people who smoke. The population doesn't love reading and has lower literacy levels. And so they preferred having infographics and visuals. They also liked having hard copies of things. And I really learned the importance of co-designing, which all the speakers have mentioned so far. And although I did have stakeholders involved in the development of different materials, that was clinicians and staff that worked with the population. And I actually didn't have someone from the population itself okaying our materials. So if you go to the next slide, I have an example of that. So this is a flyer that we used that has key information that we wanted to share with participants. And I've underlined and boxed some of the issues that participants had in understanding. And I know this is being recorded, so you can pause it. But if you go to the next slide, I kind of break down where things went wrong. Overall, it was mostly that we were using a lot of research language. So for example, principal investigator, that's what institutions use, researchers use. But to participants, it almost sounded like a PI, a private investigator, which is something that they don't appreciate. So just really keeping in mind, making sure that the language you're using isn't just research friendly, but is friendly for the population you're working with. And so overall, we did get some things right. The office hours were clear. People love that. We explained the incentive system step by step. Contact information was clear. But I should have done a better job in making it less dense, explaining some of the key terms more that are more research oriented, and making it more visually friendly. Next slide, please. And one thing that, going back to talking about informed consent, one of the ways that we measured comprehension was initially we actually just used a survey that had people read different words and that measured their literacy level. So one of the words, for example, was menopause. I'm sure a lot of people find that a hard word to say. And so what we realized was comprehension was actually higher than the survey looked like, than it seemed by taking the survey. So we switched to a teach back method where we would ask them, can you tell me in your own words what happens during the first visit? And how does the incentive schedule work? And that was a really great way to overcome some of the reading comprehension issues. Next slide, please. And I'll give it back to Theba.
Thank you, Dr. Sifat. So just to conclude this presentation and to announce some key takeaways in this presentation, health-related communications must be strategic and effective, and the strategies involved should improve the health of populations, particularly with those with lower health literacy skills or who speak English as a second language. And to reiterate some of the best practices that we've also seen in both Yawei's and Dr. Sifat's examples, it's to understand your audience, tailor messages for health literacy, which includes understanding the language being used and to limit any sort of medical or scientific jargon. It's also to choose appropriate communication methods and to monitor feedback to continuously improve your intervention. Thank you.
All right. Well, that was terrific. So thank you, all of you, for fantastic presentations. All right. So you gave us lots to think about. So we're going to spend the next couple of minutes taking some questions from the audience. So if y'all want to go ahead and put some questions in the chat or Q&A, we will start to address those. So the first question we have, and I'm, by the way, just going to throw it out to all of you so you can just decide who'd like to respond. But we do have a question about communicating to different age groups within a culture. And I think that's interesting. So would somebody like to respond to that one?
Yeah, I can take a stab at it at first, and then I can hand it over. Yeah, so one of the things that I have learned and by experience as well is that communicating different age groups is challenging, not going to lie. So one of the things that um, you can use tools, I think, for communicating with, like, let's say younger kids, right? Like early childhood age, let's say like 2 to maybe 4. Things like using puppets and using like stuffed animals and different things that engage them, ensuring that the language that you're using is very much age appropriate. So for example, let me give an example. So I started working oral health right now. What we have is like a tool, it's a puppet, and we go into these pre-Ks and whatnot, and we use the tool and we say, how many of you guys like to brush your teeth? They say yes, they say no. We say brushing teeth is important, but you don't give them too much information. You just kind of like use things that you know would stick with them. And yeah, that's kind of like my main thing. For different age groups, use things that appease to them, whether it be tools, whether it be different social media channels. For like older persons, like teens, I'd say for older persons, using like traditional media, newspapers, those things is a really good way to reach people.
Yeah, I want to add to that, just maybe focus a little bit more on the communication channel. I think with our work, just example with the Chinese community, I think with the older generation, like our approach may be more like in-person events, maybe going to the senior centers or going to church. And with some of the younger generation, I think it might be more relevant with like social media interactions. So I feel like another way to approach this is really considering going back to the community partner, right? Like if you are targeting the different age group, even within the same culture, then it might be helpful to assembly a group of like community partner that is also representing the different age groups.
And just one thing that I wanted to add to what everyone has said is, so Dr. Leader and I are actually working on an HPV self-sampling intervention. And one of the things that we want to look at is formative, like get the community's input on specific barriers. And we imagine that older folks would have different thoughts than younger folks. And so when doing that formative research, we're actually having 2 different breakout groups for the focus group session. So we'll have people in the younger demographic separate session, and then an older group as well. So I think splitting up the population so that you're sure you're getting all of the details you want in that formative stage is important.
Yeah, sorry, one more thing. I think it depends on the topic, but sometimes we, for communities, especially the ones have like multi-generation, maybe living in the same household, it might be a good approach to also considering the storytelling within the different multi-generation. Like that could be a great learning opportunity and like also like based on the strength with the community too.
Okay, so we've got a bunch of questions. Let's see if we can get through a few more. So one question is, what's an appropriate length of time to scope the community for a needs assessment?
I guess I can start with this one. I think it depends on when you start seeing a saturation of the data, when you start seeing similar themes arising. That is a good indicator that, okay, you've probably done enough formative work.
Mhm.
Yeah.
I feel like if it's a survey, no more than 15 minutes, I think hopefully maybe even 10 minutes. Like I feel like because the longer people have to fill out the survey, I think you're going to lose their interest and maybe the completion rate may also drop. Yeah.
I know we always want more information, but gotta keep that in mind. Okay, we're going to move on to another question. It's how do you think we can adapt the smoking cessation presentation to be more representative of unhoused communities across the nation and around the world?
I will say that that is a tough one. It's actually pretty hard to do this harm reduction approach in the United States because there are so few FDA authorized vapes, and vapes are not without harm. So you can really only do this research in people who have tried and failed to quit using traditional methods. Um, and I think it also does depend on, is it a rural area? Is it an urban area? So this study was done in Philadelphia, and I feel like it could be replicated in other housing first organizations, of course. Um, Places that have similar services in place, like the organization I worked with is called Pathways to Housing. And so they have a healthcare clinic right next door to them, and they work in tandem a lot. Um, which works well for my intervention because there are a lot of mental health related needs that actually the clinician on staff is part of my research team. And so we can just refer them to that. So I think it could be replicated in other clinics that have that clinical staff aspect and is a place where we know folks are going to either utilize internet or picking up their social security checks, whatever it may be.
Okay, great. Does anybody else want to add on, or do you want to go to the next question? Okay, we'll go on to the next one. How do you balance program milestones and team bandwidth with iterative evaluation as you invite and incorporate feedback from communities? It sounds like it might be related to the earlier question about how long to scope.
Yeah, I can also take a stab at this, but please, anyone else jump in. I think it can be a bit hard. So when working with community partners, they obviously have their priorities for their community. And as community-based researchers, we want to be able to give the community everything that they ask for. But sometimes the research funding that we have might be about specific research questions. So I think you have to get creative and also keep, what is it? What am I trying to say? Try to keep people's expectations in check with how much is possible to do with a limited budget. I think that's just open communication with the community partners and then letting them know that even though you might not be able to get to everything they want to do right now, hopefully in the future you could try to incorporate it or connect them to other organizations that can address whatever needs they are asking to be met.
Yeah, I agree. And then I think sometimes like the example I provided earlier with the Chinese Wellness Culinary Circle, that one is a pilot study. So we did open up to gather communities' feedbacks. I think that's actually part of the mechanism for our evaluation. Like that doesn't mean like we have to change our program all the time, like during the same time as we're hearing the feedbacks. But if there's like easy ones that is like, for example, like the background, right? Or like how we disseminate the information, like sending the slide ahead of time or print out physical copies. If it's like easy to adapt, I think we can adapt along the way. But if it's like a whole curriculum redevelopment or considering like what is the recipes, I feel like those feedbacks is definitely good to track. And I think we can have our community participants like recognize their feedbacks is being valued by the research team, right? Although we may not be able to implement it right away, but we do cherish the feedback they provide, and maybe that can help us to guide our future program development.
Yeah. Just going off of that, thinking about the example that I shared, that was something that so many people didn't know what CO was, which go figure, who knows what that is, carbon monoxide. I get that question from researchers too. That was a really easy flyer to fix, just like quick edits. So many people had questions. If it's that much of an issue, like I should fix it right away. So if you're hearing it enough from people that they're confused and it doesn't change your research question or like anything pivotal, as Yawei was saying, I think it's better to incorporate that as quick as you can.
Great.
I can just add one other piece that, and I want to really let Dr. Sifat and Yawei and Dr. Bernard speak here, but our team at Jefferson has been engaging community members in the research process as early on as possible. So when we're talking about balancing realistic milestones with activities and things, I think what Dr. Sifat said about open communication is absolutely key. And also that we invite them to work with us in developing the proposals and say, okay, what are the milestones that you think are realistic? Like, what can we hit together? Can we agree on these milestones? Can we see them together before you even get the funding or the project to do the work? Because then you're in it together from the very beginning, as opposed to like, I got money. Do you want to work together? So I know our Jefferson team has been really passionate about building our community members into even just the development of the project and the research going forward, which helps those milestones on the back end be more realistic. Also, what Dr. Safat was saying.
Okay. Okay, so how about the last question? Just some any other thoughts about using social media? Um,
Yeah, I feel like social media is a really good tool. We actually have community partners reaching out to us. I think they largely work with like Latino community, cancer survivors or patients. And one of the issues they constantly facing is the medical terminologies or jargons, like what is a biopsy? What is a immunotherapy? So we actually collect a list of like those terminologies and have our physician like do like a very short like we call them like summer Friday like terminology explanation series. So just like a very short 1 or 2 minutes like clips and we can post them on social media. So that has been like well received. I feel like social media could be a great tool. I think we just need to be like creative and yeah.
mhm.
Yeah, I agree. I think there are a lot of the tools within social media that we can take advantage of. Things like going live. We use these platforms like Zoom, Teams, but going live on a credible page, from a credible page, answering questions with, healthcare professionals is a really good way to reach a lot of people without needing them to, like register or circulating a link, using things like the question and answer box on like Instagram stories, Facebook stories. These are a lot of the tools that we can use to also counter the misinformation that is also present on social media. So it really takes a lot of work to kind of balance both. But social media definitely can be used to educate. But we just need to ensure that we are reaching persons more than the misinformation is reaching them.
With that, I think we're going to wrap up today's presentation. It was absolutely fantastic. So thank you to all the presenters and for a very engaged audience. So we will be posting recording this on our website, and we hope you all will join us for our next session on personal branding and media engagement on April 28th. Well, have a good afternoon. Thank you. Bye-bye.